Where are you guys going?
I have these people in there. Do you think it's paper on the website? When will videos be uploaded from? You can ask
I had them on my USB. I'll upload them as soon as I get home on the YouTube channel. Subscribe.
No, you put it on the. I was trying to upload it again to the same app as the site. That one happened.
yeah.
I was trying to upload it on the website.
I know how much it is.
Got a lot of images.
May I have
And they're like high resolution, so.
Yeah.
The desktop on that side.
Yeah.
How's it going so far?
Yeah, good.
Yeah.
Good.
They're uploaded. Can you double check to see if they're working for you? Is it up? I mean, it said that it just didn't work last night, but then.
There you go.
It's just here right now. Can someone check just to make sure that it's actually there? It's a labyrinth. Yeah.
Huh?
It's a labyrinth. Okay, there it is. It's to be,
I mean, people can download it on the phone.
yeah, I mean, like, as long as it works.
Yeah, it's there.
Can you let me know if someone messages you saying it doesn't work?
Yeah. That's it. Good. Cool. Can people hear on Zoom?
The mic.
Yeah.
Mike?
Yeah, all of them.
You can use anything, actually.
Can you guys see me?
Just turn it up. Yep.
Can you guys see me in the back? Whoa, it's really loud.
We have upgraded.
Yeah, Jesus. A lot better. Hello, everyone. Miss you guys. How you guys going? So today we're going to do endocrine. It's a lot of slides, about 30 seconds per slide, so we won't get through everything, but I'll try my best. And I've highlighted the most important kind of stuff. So yeah, hopefully this manages to get fit within. And this is like very similar to the one last year, because the one last year was fantastic, and I didn't have enough time to do mine properly. But yeah, this is fantastic. It'll be injustice if you didn't get his slides anyway. So yeah, so this is a quick outline of what we're going to do today, and most of it is going to be physiology, obviously, because endocrine is mostly a physiology-based kind of subject. But there's a bit of anatomy every now and then as well. All right, that's just a nice picture and anatomy. So the pituitary is just essentially the most important things are that it sits within the cell toesica, which is a recess within the sphenoid bone, and the optic chiasm sits just superiorly. So later on, I'll cover a bit where you have a tumor of the pituitary that if it grows superiorly, it can affect the optic chiasm that's just on top of it, and that causes bitemoral hemianopia, which I'll cover a bit later. And that's where it is. And it's made of two distinct halves. The anterior is made from Rathke's pouch, and the posterior is from the forebrain. And that's why they're two distinctly different areas, but they're in one gland, if you get what I mean. The thyroid now. So it's between C5 and C1, and if you have growth, it's limited superiorly by the sternothyroid bone. So it can only grow essentially inferior and posteriorly. So that's when you have, so when you have a goiter, it's going to grow down this way. That's why you have the dullness percussion around your sternum. It can be divided into left and right lobes, and the isthmus and a pyramidal lobe if you can find one as well. Yep, and that the pyramidal lobe is a remnant of its embryological growth. And if you guys have any questions at any point in time, just like put your hand up or just let me know, yeah? Or shout out. Parathyroids are just posterior, so this is a posterior view of a similar view of what we just saw, and it regulates calcium levels essentially. Superior is from the 4th pharyngeal pouch, and the inferior is from the 3rd pharyngeal pouch. That's something you'll learn in head and neck, so don't worry about it too much right now. This is a diagram, or a table, sorry, that you'll end up using next semester, so don't worry about it now, but just like keep it and save it for later. The adrenals, there's 3 main layers you need to know about: the fibrous outer layer, and the cortex, which is just outside the medulla, which is there. And the cortex secretes endocrine hormones that respond to ACTH, like your aldosterone and things like that. And your medulla secretes things like adrenaline, noradrenaline. And now to the important part, physiology. So just a quick overview of the autonomic versus endocrine systems. Just knowing kind of logically what the differences are in that one's closest to one releases into the circulation, one causes instant responses, and et cetera, et cetera. And this is a summary of the 3 major types of hormones and hormone receptors you have. So with your peptide and protein hormones, just think about with this slide, the most important thing is the hydrophilic or lipophilic, because that dictates a lot of what the rest of the functions of each of the hormones. Because if you have a hydrophilic hormone, then it's going to stay inside the cell and it's going to circulate freely in the circulation because it doesn't have to be bound to anything because it's hydrophilic. Whereas if you're lipophilic, you need to be bound to something. And the exception to that is no, there's no exception to that. No, ignore that. And the receptors as well need to know, again, pretty logically, if it's circulating freely in circulation, it can bind to surface receptors. If it's lipophilic, it can go past the membrane and go to the cytoplasm or nucleus. And I guess the amine hormones are really similar to the peptide hormones, but instead they can be stored as well. So that's the main kind of difference. And examples on the bottom. Cool. So posterior pituitary. The good thing about endocrine is that it's very buzzwordy. So you have words like magnocellular neurons and stuff like that that always correlate with posterior pituitary. So the magnocellular neurons arise from the SON and the PVN. And those are the ones that project, and from the nuclei, those neurons project into the pituitary directly to end up releasing the hormones. Whereas if you compare that to your anterior pituitary, it has parvi or parvocellular neurons that project into the median eminence, which is just here, and then that goes towards circulation, and that affects the release of hormones in the anterior pituitary. So if you have back here, this is where each of the things are. So you have the PVN and the SON up here, and they project directly into the posterior, and the anterior pituitary has projections right into the immediate eminence, and then down here they end up projecting into the circulation. Cool. Any questions about that? Great. Now, just a quick schematic for the anterior pituitary hormones. Knowing which one affects which and in what way is important. So, for example, growth hormone releasing hormone, GHRH, obviously stimulates growth hormone secretion, whereas somatostatin, SST, decreases it. Dopamine inhibits prolactin, that's probably another important one. And the rest, I feel like, hopefully you would have learned enough about. And this is another image. Maybe you would have seen this one before. And this is, so with the anterior pituitary, you have so many different hormones and they have so many different targets that it's just important to just kind of break it down into each one and think about it. Not think about it. Oh, the anterior pituitary affects this. It's this hormone affects this. Another hormone affects this. Okay, oxytocin. So oxytocin is responsible for milk letdown of the breasts, and that's important to differentiate from prolactin, which stimulates milk production. So prolactin produces the milk, and oxytocin ends up releasing the milk. And this is one of the rare occasions where you see positive feedback. So you have positive feedback when you want massive kind of reactions. So, for example, if you want to breastfeed, you want to release a lot of milk for the baby to nourish the baby. So if you stimulate the mechanoreceptors on the breast, that goes to the hypothalamus. Hypothalamus projects into the posterior pituitary and releases oxytocin. Oxytocin goes towards the glands and stimulates milk letdown. And a similar thing happens with uterine contractions. So obviously you want a massive response when you want to pass a child. So similar things happen. Not pass a stool. Someone said pass a stool. Anyway, yeah. So that's what happens there. So positive feedback for a massive response. ADH, or vasopressin, as otherwise known in America, it's responsible for water reabsorption, in the kidneys via V2 receptors. So V2 for 2 kidneys. What happens is it detects changes in osmolarity and ends up secreting ADH, which goes towards the collecting ducts, and then inserts aquaporins, which end up moving water along the concentration gradient from the hypotonic solution in the collecting ducts towards the hypotonic medulla. And that ends up decreasing your water excretion and then recycling water around your body. Another function of ADH is that it ends up being a vasoconstrictor, but that's less important, I guess, than water reabsorption. And also, the ADH is sensitive to baroreceptors, so hypotension, but this is less sensitive than changes in osmolarity. So if you have a change in about 10-15% in your blood pressure, then that will trigger a response, whereas a change in about 1% is enough to trigger an osmolarity kind of based response. Feedback loops, don't really need to go through that. Another example of positive feedback you need to know about is luteinizing hormone, but you'll learn about that in next semester when you do repro. Good fun. Thyroid hormone reduction. So I'll just put it all on the slide. So it's important to know just like what steps occur when. So follicular cells, or they call like thyrocytes or whatever, they move iodide into the cell, and they end up oxidizing it and turning into iodine, and then moving to the colloid. Then you have thyroglobulin, which is produced by the rough iron thyrocytes, and then that's moved into the colloid. Then the tyrosine residues on the thyroglobulin get iodine attached to them, and then you get MIT and DIT. MIT plus DIT is T3, DIT plus DIT is T4. And the main enzyme that's involved in this process is thyroid peroxidase. That's important to know. And that is involved with both the iodination and the coupling of MIT and DIT. And when you have that, that's kind of the storage of T3 and T4 in the colloid. And once it's needed, it's endocytosed back into the follicular cells, cleaved, and then circulated. And TSH upregulates pretty much every step in this process. So whether it comes to iodination or cleaving, it's involved in pretty much everything. And our reverse T3 is converted from T4 to reverse T3, and it has about 1% of the action of T3. So essentially, it's an antagonist because you have minimal reaction or minimal response to that. That's just another schematic for this. So kind of a summary of what I just said. Major kind of points of difference between T4 and T3 is that T4 is more strongly bound to TBG, and T3 is less strongly bound. And because it's more strongly bound, it has a longer half-life. T4 peripherally is converted to T3, and it's used as kind of pharmacological treatment for hypothyroidism, whereas T3 isn't. And that's because you have, okay, that's better. It's working? Yeah, easy. And that's because if you have circulating levels of T4, it can get converted into T3 later on. So it's kind of used as a reservoir, whereas T3 can get kind of degraded quite a bit quicker. So that's why T4 is a much nicer drug to use for hypothyroidism. Thyroid hormone goes through transmembrane receptors as it's lipophilic, and it travels to DNA and binds to nuclear receptors. And it binds DNA, and then it changes, I guess, the gene transcription within the cell. And what happens is levels of thyroid hormone change with circadian rhythm quite heavily, with max secretion between 12 and 4 a.m., and other things like exposure to cold and things like that. Main kind of functions of thyroid hormone, you need to remember, basic basal metabolic rate, temperature, and sympathetic kind of drive. Kind of went overkill with the animations, but it's okay. So knowing those kind of three is probably most important. Also, early development of the nervous system is, I probably should highlight that as well, because if you have hypothyroidism as a kid and you end up not fixing that, you can have irreversible neurological damage. Now to the adrenals. So adrenal cortex, you have three layers from out to in. You have glomerulosa, the fasciculata, and the reticularis, GFR. And your kind of typical way of remembering that is salt, sugar, sex. So I'm pretty sure you would have learned that. But the proper way it's supposed to be is salt, sugar, and sex. Sometimes sugar and sex all the time. But for exams, just go with salt, sugar, sex. And then histologically, there's a few differences. Not a huge point, but yeah. ACTH, so that's important for steroid production, and the details aren't necessarily too important. But the main points, as I said, are highlighted here. So it causes release of cortisol mainly, and androgens, but androgens are mostly done in the gonads as opposed to in the adrenals. So the main effect is on cortisol. And also it can bind to melanocortin-1 receptors on the skin, and that causes skin pigmentation. So that's something to look out for in like clinical exams or something like that. Yep, cool. Cortisol, it's similar to ACTH, as I just said. It's simulated in a lot of circumstances where you would expect like a fight or flight response. So I think sympathetic nervous system. So hypoglycemia, cold exposure, pain, that kind of thing. It's at its highest levels when you're waking up. So that's going to affect when you want to measure it. And if you have really high levels of cortisol or glucocorticoids, then you can have an effect on aldosterone as well. So you don't have to know the mechanism behind that, but just know that because you have very high levels, you can mimic kind of salt retaining effects of aldosterone. Cool. All right, so there's a lot of actions of cortisol. So you have metabolic actions. Overall, it has an increase in blood glucose and suppresses the immune system. So that's when you have steroids as an anti-inflammatory. It also stimulates the sympathetic nervous system via stimulating catecholamine production in the adrenal medulla, and it also aids bone resorption. So that's why, because it's a common drug as well, it's important to know especially what kind of actions it has, because if you have too much of something like a glucocorticoid, then it can lead to things like osteoporosis, Cushing's, which we'll cover later, and things like this. So just keep that in mind. Okay, so again, this is just the metabolic kind of function of glucocorticoids. Essentially, the main thing is that it is mainly done to increase your blood glucose and has a catabolic action overall. I've got a lot of nice diagrams. I just put them in because they're nice, but yeah, don't worry about them too much. Adrenal hormones again, a very important thing to know about endocrine is that it's a really good way to learn about conditions by just learning the hormones really well, because a lot of the time, conditions within the endocrine system end up being just hypersecretion or hyposecretion, and that really is just, if you know the hormones really well, it's really easy to follow what you can, what the effects will be. And don't worry about too much about gonadotropins or anything like that. So like androgens or whatever. That's more of next semester. Growth hormone. So growth hormone and IGF-1 are pretty much you need IGF-1 for all of GH's function, and it's made by somatotropic cells in the anterior pituitary. This isn't as nice of a picture, but it's a good picture to show kind of what happens. So it's made, stimulated by GHRH and inhibited by somatostatin, and it acts on the liver to produce IGF-1. And essentially half of the function of GH is through IGF-1 as well, and they're called indirect effects because it's affecting IGF-1, which ends up having those effects in the first place. Also, ghrelin, which is released when you're hungry, works to stimulate growth hormone secretion. And just think about any kind of situation where you would want to induce kind of growth. So like when you're sleeping, when you're exercising, after meals, that kind of thing. When your body's put under stress or something like that, then you want to stimulate the release to kind of compensate and deal with the situation. Whereas kind of in today's age with like high blood sugar levels, high fat diet and stuff like that, that can inhibit your growth hormone release. Because your body's like, oh, I'm fully satiated, I don't need to deal with too much right now. So that's why it inhibits that. So the way I remembered it, at least, was growth hormone mediates strong growth. So it stimulates muscle and bone production, and it decreases your amount of fat. And it also increases your blood glucose, which is probably another important part about growth hormone. So just remember that. And the way it actually happens is through the indirect and direct effects. So it's with the IGF-1, that's the indirect effects because it's growth hormone affecting IGF-1, which ends up having those effects, which are on the MSK. So that's protein and skeleton and cartilage, whereas the direct effects are mostly metabolic via growth hormone. That's anti-insulin, so that's increasing your blood glucose and the fat. Ignore that, not too important, just for like completeness sake. Growth hormone interactions. So knowing that a lot of different hormones obviously are important for growth is kind of a no-brainer. But knowing that glucocorticoids can inhibit growth as well is important. So pretty much it has a positive or simultaneous interaction with most things except for glucocorticoids, where glucocorticoids actually inhibit the growth and inhibit growth hormone. Yep. Cool. And insulin deficiency as well, which is important for growth, or insulin is important for growth, sorry. If you have insufficient insulin, you have leprechaunism. Again, very buzzwordy. Thyroid, as I said before, high thyroid hormone, or not high, but normal thyroid hormone is important for normal CNS development. Yep. Parathyroid hormone. Calcium, as I said before. So your bone is your main reservoir for calcium, and if you need to change levels of serum calcium in your blood, then you would want to resorb some of your calcium from your bone, and that's where parathyroid hormone comes in. And it works on a negative feedback mechanism, similar to a lot of the other hormones, wherein calcium levels, if it detects them they're high, then it's going to inhibit parathyroid hormone release. You don't need more calcium in your blood, and vice versa. High vitamin D3 has a similar action to parathyroid hormone, in that it also increases calcium. But so if you have high of one of vitamin D3, for example, you don't want too much of the other because it's going to end up having too much calcium in your blood. So that's why you end up inhibiting parathyroid hormone through vitamin D3. Parathyroid hormone works by increasing bone resorption, and it increases reabsorption in the kidney, but an important note is that it decreases phosphate reabsorption. Even though with bone resorption you're going to end up having more phosphate, what happens is because of the kidney action of decreasing phosphate reabsorption, you have a net loss of phosphate, and that's different from your from your vitamin D, from your CALCITRIOL, which ends up increasing both calcium and phosphate levels in your blood. So vitamin D, second hydroxylation step is in the kidney, and that is potentiated by parathyroid hormone as well. And as I said before, it increases calcium and phosphorus reabsorption. And that's the main kind of difference. What the hell happened there? Okay, cool. Yeah, just some nice images. That one's not as nice. I don't know what's going on there in the top left, but whatever. Insulin glucagon. So you would have learned that insulin and glucagon are potentially opposites of each other. So insulin is by beta cells, in the pancreas, and glucagon is on alpha cells. So insulin overall decreases your blood glucose levels, and it's a hormone of the fed full state. So after you've eaten, you want to decrease your blood glucose and put into tissues. Whereas when you're fasting, you want glucagon to increase your blood glucose so that your body can have more glucose. Because if after you're eating, you have glucose from your food, you don't need that. So, yep, cool. And that's just another diagram. Insulin actions. So obviously the most important is that it decreases blood glucose, and that's via inserting GLUT4 transporters in the cell membrane. And it's also anabolic for a lot of things. So what happens is it ends up building a lot of molecules instead of breaking them down, and that makes sense because they want to decrease blood glucose. You don't want more glucose in the blood, so you end up forming more glycogen. Enhances growth hormone, and for DKA, it's important to know that what insulin does is that it moves potassium into cells. I'll cover that a bit later. Histology, everyone's favorite. So, anterior pituitary has three main things: chromophobes, basophils, and acidophils. Knowing the color of each one is important. So chromophobes, phobic, poorly stained, so they're kind of afraid of staining, so they don't want to be stained. Basophils stain deep pink, and acidophils stain a pale pink. And the posterior pituitary doesn't have any of those three things. It has pituocytes and herring bodies instead. So that's a nice image of the anterior pituitary with everything labeled. And I think did you have a prac on this, on histology? Yeah? So, yeah, so like it's not hugely important, but here's a table that I made just in case you wanted to use it. Somatotrophs may be important knowing that it's like 50%. And like the names of each of the things kind of make sense given what each of them do. So growth hormone is also known as somatotropin, so that's why somatotrophs create somatotropin, lactotrophs, and etc. Posterior pituitary, so you have your herring bodies and your pituocytes as well, and that's important to know, and your blood vessels, of course. If you want to lose that, go ahead. But yeah, thyroid histology. So you have, out of all the things, it's probably easiest to recognize a thyroid under a microscope, because you have those big areas of colloid where thyroglobulin is stored, and that's surrounded by the simple cuboidal epithelium of the follicular cells, or thyrocytes, or whatever, which are called principal cells here, but there's like 3 different names. It's fine. And in between some of the follicles, you end up having C cells, which produce calcitonin, which lowers serum calcium. Not the most important hormone, but it's more to recognize that they can be there as well. Adrenal. So as I said before, there's 3 layers, and the adrenal cortex can be split into 3, as I've already mentioned. Yeah. The adrenal medulla, through chromaffin cells, buzzword again, produces mostly adrenaline and noradrenaline. Noradrenaline is less so than adrenaline, obviously. And just another histological slide. And another one. All right, clinical conditions, probably the most important one here. So, with diabetes, obviously there's a huge focus on diabetes because of how big it is. And essentially that's when you have dysfunction of your insulin, obviously. Knowing these numbers and the kind of the thresholds for diagnosing diabetes is important, and don't get them mixed up. I've covered the rest of that already. Type 1. So type 1 is an autoimmune condition, and it's a type 4 hypersensitivity where your cytotoxic T cells attack your beta cells in your pancreas, and you need to have lost about 90% of your normal beta cell function before you get like very severe symptoms. So polyphagia, polyuria, polydipsia, your 3Ps. So your main treatment modality for type 1 is going to be insulin straight away. And a very important complication of type 1 is DKA. So what happens here is that because your body doesn't get glucose into its cells because of dysfunction or like a lack of insulin, then your body's going to perceive that as a fasted state because it can't detect glucose in your blood. So what happens is it goes towards an alternate energy source, which in this case would be keto acids or ketones. So with ketones, the problem with ketones is that they're acidic. So if you have too much keto acid production, you're going to end up being acidotic. And what happens here is you end up having to breathe a lot more to remove your CO2, which is an acid, which is a volatile acid essentially, to increase your blood pH to remain equal. And you end up having hypokalemia because what happens is your body wants to get all the acid out of your blood. So one way it does it is through breathing out all the carbon dioxide. Another way is by kind of shoving all of the hydrogen ions into the cells, and to remain electroneutral, it ends up pulling potassium out. So you have too much potassium in your blood, and that's the source of a HAGMA. So what happens normally is that exchange occurs, and insulin does the opposite. Not complete opposite, but it ends up moving potassium out of the blood into the cells, so that kind of keeps everything balanced. In DKA, however, you have too much of your hydrogen, and you essentially lose all of your potassium from your cells, and that's going to make you have hypokalemia in your blood, and that's a problem with your with all of your cardiovascular kind of problems like your arrhythmias and stuff like that. So your main treatment kind of protocol for DKA is first you give them IV fluids to rehydrate them, and then you give them insulin to move the potassium back into the cells and to lower the blood sugar levels. And because you're administering insulin and it moves potassium back into cells, you end up having a situation where you have too little potassium. And so then you have to monitor your potassium and make sure that you have enough. So that you may end up having to add more potassium later on. Type 2. So this is the one of insulin resistance, which is the more common one. It presents later in life, and there's a greater genetic risk and greater lifestyle risk as well with type 2. Yep. The pathophys. So your body tries to compensate, and the body's really good at compensating in the short term by producing more insulin, but long term it doesn't really think about the consequences. So what happens is it produces more insulin, and your pancreatic islet cells, your beta cells particularly, end up undergoing hypertrophy and hyperplasia, and then it also produces islet amyloid polypeptide, not the most important thing, but knowing that it can end up causing atrophy and hyperplasia in the pancreas is important. Yeah, it's probably the most important things. Complications. So the biggest thing with diabetes is that it can cause vessel damage, and the way that occurs is through ROS and things like that, causing too much inflammation in your blood vessels and destroying them. And that can end up affecting your microvascular circulation, your macrovascular circulation with subsequent complications. Probably shouldn't have highlighted the middle 3 bits, not too important, but yeah. So, very important slide. Your 3 microvascular and 3 macrovascular, just remember them, please. They love asking these questions in exams. Retinopathy, neuropathy, both peripheral and autonomic as well, don't forget that. And nephropathy, in macrovascular being like your AMIs, your strokes, and your peripheral vascular disease. And this is a quick table I made about the differences between the two. So prevalence is higher in type 2 and the age of onset is a lot higher. Risk factors a lot clearer. With risk factors for type 1, it's mostly autoimmune conditions. And when you have one autoimmune condition, you're more likely to have other ones as well. There's a stronger genetic link. DKA is probably the biggest one between type 1 and type 2. You can get type 2 DKA, but it's very rare. So, and in Monash world, like they don't ask about that. They're going to ask about type 1 causing DKA, so don't worry about that. Yep. Oh, and with type 2, your first treatment modality isn't going to be insulin. It's going to be things like metformin instead. Whereas type 1, you're insulin dependent. So insulin dependent diabetes. Pituitary adenomas. So this is what I mentioned before. So if you have a cancer in your pituitary that ends up enlarging your pituitary, what happens is because you've got the optic chiasm above it, you're going to essentially impinge the optic chiasm, and you'll learn this in neck later in the year, but it causes loss bitemporally, so on this side and on this side, not in the middle. Yep. And knowing, again, which hormones are affected and knowing how each hormone works is important to recognize in order to understand what each pituitary adenoma does. Because obviously, an overall pituitary adenoma will cause all these different things, but it can be more isolated in the sense that it can cause changes in just growth hormone, or just luteinizing hormone, or just prolactin, for example. So just important to recognize those things. An important one is prolactinoma. That's when you have too much prolactin, as the name suggests. And the buzzwords here are erectile dysfunction, amenorrhea, and galactorrhea. You can have panhypopituitarism, which is a loss in all of them, which, as the name suggests. Diabetes insipidus, not to be confused with diabetes mellitus. When you have decreased ADH, that ends up causing you to urinate too much, and then you have to replace that too much. That's polyuria, polydipsia. And syndrome of inappropriate ADH secretion, which, as the name suggests, ADH, you have excessive ADH release. And the way to treat these is always through a transsphenoidal surgery. So you'll learn about the sphenoid later, but it's going through the nodes essentially to the pituitary, which is just like through there. Yep. So growth disorders. So growth hormone, if you have it during childhood, you end up being gigantic, as gigantism, as it suggests, because that's because before your epiphyseal plates fuse, so you end up having everything grow so much. Whereas with acromegaly, that's after your epiphyseal plates fuse, so you have enlargement of your bones, like your hands and feet, and very distinct coarse facial features. The other presentations are probably less kind of clear than your enlarged hands and feet for acromegaly and things like that. But just think about if you have like a lot more bone, a lot more mass about you, you're gonna have like osteoarthritis, you're gonna have deformities, you're gonna have skin thickening just to kind of compensate for that. OSA, that kind of thing. So the left is gigantism and the right is acromegaly. So you have the enlarged nose and large ears, just very clear visual facial signs. More growth disorders, so leprechaunism, as I mentioned before, is an insulin receptor defect. Laron dwarfism due to defective IGF-1. And surprisingly, this is the one that like has anti-aging effects and like is effective against diabetes and cancer. It's like what? But yeah, just knowing not too important to know like the main mechanism is just to recognize that leprechaunism, insulin, Laron dwarfism, IGF-1. So primary hypothyroidism, as the name would suggest, primary relates to the thyroid gland, and just knowing that, knowing where the disorder originates is important to recognize because that affects your later investigations of TSH and T4. So if you have a problem with your thyroid and there's hypothyroidism, you end up having increased T4 levels and decreased TSH because of negative feedback. And always just think about negative feedback in these cases. But if you have a problem with your secondary hypothyroidism, your TSH levels in your adrenals, because it's insensitive and the problem is not in the thyroid, then you end up causing too much problems, and there's no negative feedback to the pituitary instead. Sorry, pituitary, not adrenals. So that's why you end up having high TSH and high T4, and the high T4 doesn't negative feedback because the pituitary is insensitive to that, and vice versa. Hypo and hypothyroidism are have pretty classical pictures, mostly pertaining to like having too much of something with hyper and having too little of something with hypo. So you have your intolerance to cold with hypothyroidism because you're not having enough basal metabolic activity, and your hyper is when you have too much of everything. So your tachycardia, tremors, that kind of thing. Graves' disease, so that's autoimmune thyroid-stimulating antibodies that are produced towards the TSH receptors in the thyroid. That causes overstimulation, toxic nodules, which is essentially functional adenoma, and your subacute thyroiditis, which starts as elevated thyroid hormone because it ends up releasing the stores from the colloid, but then it declines to hypothyroidism as you deplete those stores. Hypothyroidism, most important, is Hashimoto's, autoimmunity against thyroid, just destroying the thyroid, and you can end up having a similar thing where you have elevated thyroid initially. Iatrogenic, most important being amiodarone, for things like AFib and ventricular tachycardia, because that's an iodine-rich drug, and that can cause hypothyroidism as well. Hyperparathyroidism, overactivity, very self-explanatory, these things. Secondary is probably important to recognize because if you have, for example, renal failure, then you're not converting vitamin D properly to calcitriol, which is the second hydroxylation step, occurs in the kidneys. And because you don't have vitamin D to increase your blood calcium levels, you end up having to increase your parathyroid hormone secretion. Hypocalcemia, with the mnemonic stones, bones, moans, and groans, that's pretty buzzwordy as well when they mention that. And hypocalcemia is Shovstek, and Trousseau's sign. Adrenal insufficiencies, so Addison's is your main one, which ends up being inadequate cortisol and aldosterone production. The main ones, just think about, again, if you have inadequate cortisol and aldosterone, think about what it does. So if you have inadequate aldosterone, you're not retaining enough salt, so you end up having salt cravings, and things like that. How you going, Connor? Hypercortisolism. Cushing's disease is when you have pituitary adenoma, and that's the disease is the pituitary adenoma, whereas the syndrome is just anything that can cause excess cortisol in your blood. It can be caused through ectopics or some other kind of tumor, or some kind of exogenous use, so your glucocorticosteroid use. Clinical presentations, the most important ones and most kind of clear ones are listed there, underlined. So your buffalo hump, your central obesity, osteoporosis, big one as well. Again, we're just highlighting why it's so important to understand what each hormone does. hypercortisolism with a dexamethasone suppression test. This is a question I've asking as well. So it's important to know that what the etiology of each of these things is. So with Cushing's disease, it's a pituitary ACTH tumor, which ends up being responsive to high-dose dex, whereas adrenal tumors, when you have such dysregulated production that you don't need a stimulant like ACTH, you just don't get suppressed at all. And your ACTH levels actually get decreased because of negative feedback. So that's something just to remember. THYROID. So THYROID is a catecholamine secreting tumor, and catecholamines mediate a lot of the sympathetic nervous system activity. So that's going to end up with your clinical presentation with your anxiety, panic attacks, hypertension, palpitations, that kind of thing. Congenital adrenal hyperplasia. Do you have a PBL on this? Yes? No? No? Okay. So what happens here is you have a partial total defect in synthetic enzymes in your adrenal cortex. So most of the insufficiencies lie in 21-hydroxylase. And I'll just show this through here. So what happens is, because you don't have that enzyme up there, you end up kind of shunting the production from cortisol and aldosterone towards your androgens and estrogens. So because that happens, you have decreased cortisol, which doesn't feed back, towards the ACTH. So your body thinks that you got low cortisol, which you do, and your body tries to produce more ACTH to stimulate more cortisol production. But of course, that can't happen because you don't have that enzyme. So an important thing to note for this slide as well is that the one in the yellow box, 17-alpha hydroxyprogesterone, is what's tested for CAH most of the time. Because if your rate limiting step is at that point and you can't produce anything below it, you're going to end up producing more of the 17-alpha. Hyperaldosteronism, again, just think about what aldosterone does, hyponatremia and hypokalemia if you have too much. Osteoporosis, DEXA scans of negative 2.5 or lower end up being diagnostic of osteoporosis. And it's especially important post-menopausally because estrogen ends up producing osteoprotegrin, which is kind of a decoy and binds to rank ligand and stops osteoclast activity. So after menopause, you don't have any more estrogen, or very low levels at least, and that ends up making your body more susceptible. And there's many risk factors like hypothyroidism, which ends up being catabolic, diet, physical activity, that kind of thing. Most important thing being rank ligand on your osteoblasts and rank receptors on osteoclasts, and osteoclasts being resorption, osteoblasts being deposition. And you don't have symptoms until you break a bone, because you don't feel symptoms from having a low density bone. You end up having symptoms if you break that low density bone. And prevention is like supplementation, that kind of thing. Cool, so let's get to questions. Got a few minutes. So, yeah. Which of the following is correct about ADH? You can just yell it out if you want to. If not, I'll pick some of you. B? Okay, so ADH, you're thinking about aldosterone. So aldosterone is the one that increases salt and water reabsorption because it ends up in the distal convoluted tubule having more salt reabsorbed and water comes with it. Whereas ADH urine, it ends up, because you insert the aquaporins into the distal, into the collecting ducts, you increase the osmolarity in the urine because you're removing water from it, whereas because you're returning water to the body, you're decreasing your plasma osmolarity. Yep. one doesn't the anterior pituitary secrete? D? Very good. Which is not directly involved in glucose metabolism? C? Very good. Parathyroid hormone, which is correct? Perfect. Anterior pituitary secretion is deficient. The child will have what? B? Very good. If there's inadequate carbohydrate intake, secretion of insulin will result in what? You guys are gunning it. This is fantastic. Absence of thyroid hormones will cause what? B or D? B. Very good. ANP secreted by the heart has the opposite function of which hormone from the zona glomerulosa? D. Because the only thing that the zona glomerulosa does is aldosterone, salt sugar sex. Decreased cortisol will result in what? Decreased cortisol. Decreased cortisol. Hyperglycemia. Yeah, because cortisol ends up increasing blood sugar. And if you have too much cortisol, you're going to get immunosuppressed because the cortisol is an immunosuppressant. So what happens is it is anti-inflammatory, that kind of thing. Cool. Increased growth hormone will end up doing what? So strong growth. So you have increased muscle, increased bone, and decreased fat. Not cool. Sorry. Any answers? Very good. That's going to be your ADH. Think about the level that each of these are released at. No ideas? A. To the pituitary. Hypothalamic. So would that. Very good. See? Very good. See? Very good. To think about what ADH wants to do, So if you have too much water, again, you don't want more water in your body, so you want to get rid of it, so you're going to decrease your ADH secretion. See? They're a healthy patient. So if you end up having increased DEX, then you're going to suppress, because this is thinking about DEX versus cortisol. So DEX is exogenous, cortisol is endogenous. So if you have increased DEX, that's going to feed back onto your ACTH levels. That's going to decrease them. And then decreased ACTH will end up decreasing your cortisol levels. Yep. Last question. D? C. So this is the CAH. So that's when you have enzyme deficiency, don't have enough cortisol produced, low cortisol, ends up feeding no negative feedback. Oh, sorry. There's not enough detected, so then you end up producing more ACTH. But then the enzyme doesn't go through, so yeah. And that's it. Thanks, guys. And that's the diagram before. So with the dopamine, there's no kind of positive mechanism. It's mostly dopamine. So if you have decreased hypothalamic secretions, then you're going to end up increasing prolactin. Cool. Basically this. Oh, no.
Take like a 5 or 10 break before we start. I'll yeah. Oh no, it's mine.
It's the big one?
It's the big one, yeah.
Big one. Okay.
It's the big boy. Well, the lecture hall is booked until 5.
Wait, if I'm just trained, I can just tell me that.
That's all you do.
Do people want a 5-minute break or not? Hi.
5 minutes break.
Wait, what are you doing? Look, we've got to 3 hours without that.
I'm happy to do a 5-minute break. Yeah, it's hard to go like back to back, and it's gonna be busy.
Oh, so this where's the Zoom recording?
It's yeah.
Is that gonna have any? Does that have sound?
What do you mean?
Quite chose. Maybe that's why I got given.
Like recorded sound?
As in, can the people in the Zoom actually hear it?
Yeah. We can see like
Well, I mean, it's alright. We have to be
Because you've got this.
as where's Kran?
No, it's alright. I got it. So you don't actually need to be on Zoom on here.
I don't know. Karan's the one who.
Yeah, that's alright. Yeah, I missed him this morning.
I mean, I haven't started saying anything yet. I think it's, I just want to enjoy it and kind of reply to people's messages. That was that all fucking messages.
I looked at what I had because I did get that friend.
I don't know how to turn that off. I don't know if we need it.
This one. I don't even know. That's this, isn't it? Why has he got document camera on the stream too?
Everything's being recorded. Answer.
How did you set, where are you signed in here to get the document camera?
I signed up on the computer and then added the meeting room thing via the call function.
I'm just wondering where this screen is coming from, because that's a live stream of the document camera.
That's the Zoom running on this computer has this as its camera.
How did you get that as the camera?
That's the native camera.
Is that how it's wired? That's pretty cool.
I think that's how it is.
So you don't actually need to sign in on the Zoom on the computer.
Okay.
That's the beauty of it.
Okay.
So you can just, you start the call and then you call in through this. And then it sends whatever's up on the projector through to Zoom automatically.
Okay.
So you don't actually need to start Zoom on the computer.
Okay.
And I might actually turn it on. I mean, it's working. But I'll hang the Zoom up on the computer.
Yep. Would that change the code or?
No, it should be fine.
Okay, yep.
Right? You just leave the meeting.